Hello, I'm Brian Darlow, an academic neonatologist from the University of Otago, Christchurch in New Zealand, and today I'm going to be talking about anti-vascular endothelial factor therapy for retinopathy of prematurity. I have no conflicts of interest, but I will be discussing off-label use of a number of drugs. The objectives of this talk is to enable us to talk about the pros and cons of anti-VEGF therapy for severe retinopathy prematurity, to know the reasons behind the concerns that intravitreal anti-VEGF therapy may have serious systemic side effects, and to be able to carefully consider the most appropriate therapy for type 1 ROP for each patient. Vascular endothelial factor, growth factor, is a family of proteins of which VEGF-A is the key angiogenic factor, and VEGF-165 is the most abundant splicing isoform. VEGF is produced by many cell types around the body, in the retina specifically by three different types of glial cells: vascular endothelial, retinal pigment endothelial, and ganglion cells. VEGF binds predominantly to the membrane-bound VEGF receptor 2, releasing tyrosine kinase, which is the key intracellular orchestrator of the complex cascade of angiogenesis. VEGF has many other actions around the body. In the central nervous system, it's neurotropic, neuroprotective. It maintains the blood-brain barrier. In the lungs, it has a key role in alveolization, and it also has key roles in bone growth, cardiac and kidney development. For the purposes of this talk, it's important to understand that retinopathy of prematurity has a two-phase pathogenesis, and in the proliferative second phase, there are very high levels of VEGF, which are produced by the avascular retina. An intravitreal anti-VEGF neutralizing antibody was first shown to be effective in suppressing vasoproliferation in the eye of a murine model in 1995. And there are currently 4 candidates for anti-VEGF therapy. Bevacizumab, which is a humanized monoclonal full IgG antibody. It has full VEGF-A blockade, and it's been used widely off-label for adult forms of eye diseases, age-related macular degeneration, diabetic retinopathy, since about 2005. Pegaptabnib is an RNA oligonucleotide which binds very tightly to the VEGF-165 isoform and has approval for some forms of age-related macular degeneration and other adult eye diseases since 2004. Ranibizumab is a humanized antibody fragment, has full FGA blockade and greater affinity than bevacizumab. It has FDA approval for some adult forms of eye disease since 2006. And finally, aflibercept is a receptor fusion protein which binds very strongly to all forms of VEGF and has approval for adult eye diseases since 2011. It's also important to understand that laser is an established local treatment for retinopathy prematurity, and it was established in a well-designed randomized controlled trial with now long-term follow-up. So eyes with so-called type 1 disease are the stage that the eyes are treated, and that is 90% successful with laser therapy. But at 6 years of age, 25% of treated patients will have visual acuity 2200 or worse, and a third will have high myopia. Intravitreal bevacizumab has been considered for ROP because it's cheap. It's been wonderfully successful in adult eyes with proliferative disease. Giving it generally does not require a general anesthetic, and the technique of intravitreal injection is easier to learn than laser therapy, and it's potentially less destructive than laser therapy. So for these reasons, it's been used quite widely for ROP since about 2007, off-label. The BEAT-ROP study was a landmark randomized controlled trial of intravitreal bevacizumab compared with laser in 150 infants and published in 2011. The primary outcome of this study was ROP recurrence needing treatment before 54 weeks post-menstrual age. And intravitreal bevacizumab treatment was found to be significantly better than laser therapy for zone 1 disease. But there were many limitations of both the study design and its interpretation. and it's now recognised that late recurrence of the acute retinopathy changes can occur even as far out from therapy as a year later. And now there are a number of papers that have reported recurrence is really quite common and well beyond the endpoint of the BEAT-ROP study. The BEAT-ROP study was also not powered to assess mortality or morbidity in either the short or the long term. So is intravitreal anti-VEGF therapy safe in preterm infants? Well, we simply don't know because of a lack of data. But absence of evidence of harm is not the same as evidence of no harm. And neonatology has many examples of therapies being adopted because of short-term benefit ahead of proper studies. Neonatologists of my generation very routinely gave a course of postnatal steroids to a baby who was still on a ventilator at a week of age because we were able to wean that baby off the ventilator. And it was only some years later that it was discovered that this practice led to an increased incidence of cerebral palsy. We know that there is harm of these therapies in animal models. For instance, newborn rats given a single systemic dose of a VEGF receptor inhibitor rapidly develop changes that almost exactly mimic the pathology of bronchopulmonary dysplasia, and these changes persist into adulthood. So one of the problems of detecting harm from anti-VEGF therapy is that it may be very similar to the normal morbidity of prematurity. Does intravitreal bevacizumab escape into the systemic circulation? We know that it certainly does. These are macaques given the same equivalent dose as used in the BEAT-ROP study. The top line here shows the amount in the vitreous of the injected eye, and it gradually decreases in concentration over about 8 weeks. The second line shows a slight rise, and that is the bevacizumab in the serum, so a peak is reached at a week of age, and it's still half that at 8 weeks. And the bottom line shows that some of this drug also gets into the contralateral non-treated eye. There are human data from infants who've been first treated with laser and then bevacizumab, and most recently from Taiwan, a group of children who have just been treated solely with bevacizumab, and it shows almost exactly the same data as you see in the macaque monkeys. And it's also important to realize that the concentration of bevacizumab in the serum is 1,000-fold greater than the concentration of VEGF. Most recently, there has been some reports of harm from bevacizumab. This comes from the very large Canadian neonatal network, where babies treated with bevacizumab were compared with babies in that network who had had laser therapy, and they all had Bailey 3 neurodevelopmental assessment at 18 months of age. And what this slide shows is that babies treated with bevacizumab had a lower Bailey 3 motor composite score. They had higher rates of neurodevelopmental impairment and severe neurodevelopment impairment. These are all unadjusted for confounding risk factors, but when that adjustment was made, there was still a higher rate of severe neurodevelopment impairment in babies who had been treated with bevacizumab. It's just important to recognize that babies treated with bevacizumab were slightly sicker. They had higher scores for neonatal acute physiology, and they more often had zone 1 disease, and both those factors tend to be associated with worse outcome. So in conclusion, intravitreal bevacizumab does escape from the eye, and high concentrations of the drug are found in the blood for several weeks. At the same time, blood concentrations of endogenous VEGF fall to well below normal values. In preterm babies, VEGF is involved in multiple ways in normal development of major organs, and these babies frequently have damage to these major organs, so it may be difficult to quantify further harm from anti-VEGF agents. Laser therapy is established, safe, and largely successful. So anti-VEGF treatment should only be used in limited circumstances. It can be considered for aggressive posterior ROP, for other zone 1 disease, if there's a poor view of the posterior retina. But it must be used with fully informed parental consent, and its use requires regular and long-term follow-up. So thank you very much for your attention.